So what you're not being told about vitamin D could reduce its effectiveness considerably for you, and that's going to be important. And here's, for instance, from a recent headline, there's a number of videos that have come out about this as vitamin D cuts COVID deaths in half, and that's from the last month. And it was due to a study we're about to go over a little very briefly. But the point is this: the second thing we learned from COVID, and all the research is coming in from around the world and all these other countries that actually didn't have the vaccine or couldn't get the vaccine, and they had to say, how can we treat these people in front of us? What do they need? And they started looking at things like vitamin D and glutathione and so on and so forth. This suddenly made the world wake up, if you're paying attention, to, gosh, if we do things for ourselves, we will reduce the chance of getting seriously ill for the next flu season or pandemic or whatever you want to call it. I'll call it flu season, okay? So the second thing we learned from COVID that will change how you will protect yourself for the next flu season, what we know and what has been discovered from the data collected through the pandemic. Number two is glutathione deficiency limits the effectiveness of vitamin D. That's a big secret that has not been known before post-COVID, or actually just before COVID. Glutathione deficiency limits effectiveness of vitamin D. The conclusion of a study that vitamin D supplements widely consumed by the public are likely to be unsuccessful unless reduced glutathione status is also corrected. In other words, you need to increase your reduced glutathione status. This is a new undiscovered mechanism by which reduced glutathione levels determine the bioavailability of vitamin D. So when you see these headlines of vitamin D could reduce the deaths by 50%, it means two things really. It means that those people who die because of vitamin D, they were deficient. So if you give vitamin D to them, you'll get a boost. But if they weren't deficient, the other factor is that they might have been glutathione deficient. And that also came out of the pandemic widely. We've talked about that in previous videos. So it's not just vitamin D deficiency, it's reduced glutathione deficiency. You give these two things, which you can get individually and in the hospital, and you can even get IV, make a tremendous difference. Tremendous difference. I can't express how amazing this is. So this is why this study is different than previous studies. Glutathione stimulates vitamin D regulatory glucose metabolism genes, lowers oxidative stress and inflammation, and increases 25-hydroxy vitamin D levels in the blood. A novel approach to treat 25-hydroxy vitamin D deficiency. 25-hydroxy, we'll get into that. About the deficiency of vitamin D, big picture first, okay? Vitamin D decreases 13% per decade of life. So is that no matter where you are in the world, as you're getting older, it gets less? Generally, this is true. So when you say, hey, you got to go out and get some sun and get your vitamin D, we become progressively more inefficient synthesizers of vitamin D as we get older. But there's things we can do to make us more efficient synthesizers of vitamin D. You can take it, get some sun, get glutathione, and a few other secrets we're going to talk about here. So at the age of 70, it is approximately half that produced by age of 20. So notice the populations that died and had the highest morbidity and mortality from COVID in the previous pandemic of 1918 to 20 were over 50. This is one of the factors that they have in common was vitamin D deficiency and glutathione deficiency. Here's the study that a lot of people have talked about just in the last few weeks. Protective effect of vitamin D supplementation on COVID-19 related intensive care hospitalizations and mortality. Definitive evidence from meta-analysis and trial sequential analysis. So what does that mean? It's their way of filtering. They have an even more refined way of filtering all previous other studies and saying, do we have a correlation here? Can we say this or can we not say this? Were these studies done? So what they call TSA, trial sequential analysis, is their method here. That's the new part. So their conclusion is vitamin D administration results in a decreased risk of death and ICU admission. The protective role of vitamin D in mortality risk shows positive results. Discussion: the results suggest a definitive protective role of vitamin D in ICU hospitalizations. So this is saying, but didn't we already know this? We did know this, but what this is saying is that there's a lot of little flimsy studies out there that really got through all the data and said, even though there's only a few really good studies, these studies absolutely clamp down, make the association that vitamin D builds your immune system, okay? And so the reason I put this little map in, it's an Italian study, and most of the really good work came out of Italy through the pandemic in terms of all these other things they looked into. It didn't happen in the United States for the most part. It happened in Europe and actually Southeast Asia and even the Middle East. So it's from the University of Palermo in Sicily, and that's where Sicily is the end of Italy. There's Tunisia, there's Malta. All right, so let's be fair. Let's put Italy in the context of the pandemic. This is about the ability to contain the virus when you talk about deaths per 100,000 of the population. So deaths per 100,000 is kind of a crude metric. What it basically is saying is can this country, can this culture, whatever the geography is we're measuring, can they contain and keep the virus, the infection, whatever it is we're talking about, from spreading? So if they have a low number, they've done really well and they've minimized the overall effect on their population. If it has a large number, they couldn't contain it, it just got away from them. So we have Peru on the top, obviously did very poorly. A lot of people died there and got very sick. But over here, when we talk about observed case fatality ratio, that's really about the healthcare. So those people who came into the ER or the ED, they came into the hospital for help. How did they do? Did we help them? Well, Peru's in the top of both lists. They obviously have poor health care and they didn't have the ability to limit the spread of the infection. But in terms of crude deaths of containment, the US was second worst outside of Peru. How's that? All right, so about the healthcare though, US is kind of in the middle, but this is about Italy. So Italy is really close to halfway down in terms of its ability to contain the virus infection, but it actually is much further down, which is better certainly than the US and certainly Peru and everything else in terms of healthcare. So this is the two differences. And they were very concerned and they did a lot of really good research. But look at the best outcomes. So the country that could contain the COVID the best was Japan, and the best healthcare was Japan, yes, but also Australia and South Korea. Okay, so we're talking about vitamin D sufficient and low vitamin D. So these are categories: sufficient, deficient. We'll get into it. Basically, if you're low on vitamin D, what happens is you can't control. You have no, if you're sufficient, which means actually 30 and over vitamin D, you can support your immune system to an extent, right? You have greater antioxidants, greater anti-inflammatory actions, etc. These are all the things that it promotes. I'm not going to get into that. It decreases COVID-19 severity. That's done, that's known, that's true, not a dispute. So sufficient vitamin D, which was that over there, will change your immune response. It will support your immune response. Low vitamin D, hence in red, will do just the opposite. You'll have a decrease ACE2 inhibitors. You'll have increased ACE1, so you get vasoconstriction, hard to believe, hypertension, spread, ARDS, advanced respiratory distress syndrome, and so on. And so this is pretty straightforward, known very well. So risk of death due to COVID by vitamin D status, risk of death, risk of severe COVID infection. So death, severe COVID infection, pretty much have the same story. Vitamin D sufficiency, vitamin D deficient and insufficient. Being deficient, insufficient, it's higher risk, 107% higher risk with vitamin D deficiency or sufficiency of death due to COVID. Here we go, 90% higher risk of vitamin D deficiency, insufficiency of severe respiratory. So you got the point, right? So deficiency is below 20, insufficiency is 20 to 30, and sufficiency is above 30. So that's a pretty low bar, actually. So COVID-19 disease severity by vitamin D status. And again, it says deficient vitamin D is red, insufficient, remember that's 20 to 30, and then sufficient above 30. So what we're saying is asymptomatic, if they were asymptomatic, they didn't really have any problem, and yet they were COVID positive, 100% of them were, that's green, they were sufficient. They had over a measurement of 30 nanograms per milliliter. Moderate, kind of in the middle, all three. And so let's jump down here. This is severe critical, 80% were deficient. So it's pretty black and white. And this comes out of a group called Grassroots, and they have a lot to do with vitamin D. Pretty interesting. So glutathione vitamin D connection. What is the primary cause of severe COVID illness? Glutathione or vitamin D deficiency. Is it the chicken or the egg? Don't really know, but you're going to know at the end of this. All right, remember the glutathione gap. We've talked about this in a number of videos. The glutathione gap is, as we get older, our glutathione amount, our ability to make glutathione decreases, kind of like vitamin D. And so our glutathione decreases, our oxidative stress increases. So the gap is the difference between what you need to reduce the oxidative stress and what you have, the amount of glutathione you have on hand. as you get older. So it gets worse as you get older, but now that we know that, there's things that we can do directly to improve that. That's the point of this, not to go, oh, bummer, it's getting worse as you get older. Oh, bummer, that's true, but you can do things like other generations couldn't do. So that's a good thing. So vitamin D and lysine, which is part of glutathione levels, correlate positively with glutathione levels. Makes sense to me. But they correlate negatively with insulin resistance levels, meaning the more insulin resistance, the less glutathione and the less vitamin D. Pretty interesting, huh? So that's from type 2 diabetic patients, 2014, vitamin D status is independently associated with plasma glutathione, reduced glutathione status in adults, 2014. So this is going in to the pandemic. So why didn't we do this? Why didn't we have this available in all the hospitals? Pretty easy. They're now down to supplements. They could have done it IV. They could have done it by oral. The study shows a positive relationship between vitamin D and cysteine, and reduced glutathione. How could this be true? Let's look at the big picture. So vitamin D, how you get vitamin D? You get it from the sun, of course. You get it from what you eat, meaning fish oils, so salmon and so on and so forth, or you can take supplements. That's a vitamin D, and from the skin to vitamin D, goes to the liver changes it, adds a hydroxyl group, goes to the kidney, which adds another hydroxyl group. Now it becomes active. This is a thing that's doing all the work through the whole body. It is a hormone. And so this goes to prevent or treat viral respiratory disease, cancer, osteoporosis, heart disease, multiple sclerosis, diabetes, and hypertension. Another question you can ask, why don't they measure vitamin D levels in cancer patients in conventional medicine in the United States? And I would say, that's a good question. So it has a lot to do with maintaining calcium status. So it's the vitamin D is the strongest correlation with osteoporosis and osteopenia, women and in men, but mostly it's women. And secondarily, it's the calcium. It's almost never the calcium. Vitamin D3, K2. So the connection is the liver. One, the liver has to act on vitamin D so that the kidney can in turn turn it into a hormone. So the liver is this. Vitamin D comes along and already has one hydroxyl group. It adds a hydroxyl group. So now it's two hydroxyl groups. And the kidneys add another hydroxyl group. They're all doing the same thing, so to say, right? So this is why you have 25 hydroxy vitamin D. 25 hydroxy, that's where we're measuring this. They're adding a hydroxyl group. And the kidneys add another hydroxyl group, and that's called 125 vitamin D. So there's two hydroxy groups added to the original. Not that you needed to know that, but this is what's measured in the labs, which is 25 hydroxy, 25 OH vitamin D. Notice this though, diol versus triol. Diol versus triol. Proactive hormone, calcidiol. The active hormone is called calcitriol. The degree of liver dysfunction is directly related to its ability to create glutathione. Really important. Its ability to create glutathione. You need to have to reduce glutathione. So stages of liver disease, normal, fatty liver, liver fibrosis, cirrhosis. So cirrhosis isn't all about alcohol. It's about other deficiencies such as choline deficiency. And that starts way back here. So you can have fatty liver due to alcohol and other toxic exposures, by the way. And you also can have fatty liver, what they call non-alcoholic fatty liver, which is really from, again, a number of other things, but primarily from choline deficiency. So normal liver has 100% ability to reduce glutathione. But as it becomes choked, as it starts to lose its functionality, or as its inability, as its presence of glutathione decreases, the liver becomes diseased and goes to cirrhosis. So a cirrhotic liver is 100% glutathione deficient. A normal liver is 100% glutathione replete or full. If your liver is compromised, it can't convert vitamin D effectively. So the point was, glutathione is the juice, it's the battery. It's like having a flashlight that has a poor light, you change the batteries and boom, it's as good as new. That's the glutathione, is the juice for the liver that does so many functions for the rest, metabolic functions for the rest of your body. So its ability to convert vitamin D, add that hydroxy group to pass it off to the kidneys, is directly affected by its glutathione levels, reduced glutathione. If it doesn't have enough reduced glutathione, GHS, its ability to activate vitamin D is decreased, limited, compromised. So what do the labs show? Here we go. Here's just my spreadsheet and one of a number of pages, but I couldn't put everything out here, and I'm just giving you a shot, and I have a better way of looking at it than this. But here's a spreadsheet, and I know it's blinding, and I'm going to change that for a second for you. So this is high. Everything here is sorted from vitamin D, high vitamin D to low vitamin D, right? So now we drop down, we're going to see, are there any other relationships? We looked at cholesterol, omega-6-3 ratio, insulin resistance, insulin, glucose, hemoglobin, so on and so forth. We're not going to look at all of these, we're going to look at the relevant ones, okay? Let's go. So this is what they call a scatter plot. And I recently learned to do this from somebody in one of our groups said, hey, you ought to do this. It's pretty interesting. You got so much data. So I started doing it, and it really defines the relationships we're looking for. So I've talked about vitamin D, obviously, right? So vitamin D measured against the omega-6-3 ratio, right? We want a 1-to-1 ratio. So the ideal ratio of omega-6-3 is 1-to-1. And I've talked about that in podcasts and videos. Just take my word for it at this point if you haven't heard that before. But the ideal target for vitamin D is a constant 70, 80. You know, it goes up and down. Of course it is. But if you can have 70 and you lock it in, you're good for life. Most people get deficient and then they overcompensate and get deficient, overcompensate. But if you could lock it in at one level, around 70 would be fine. Okay, there we go. So what does this show us? I just threw this data in there about vitamin D and the omega-6-3 ratio. And what it shows me is really interesting, is that as you get to your target for the omega-6-3 ratio, a 1-to-1 ratio, your vitamin D will be at the ideal level. Or you could say it another way, if you get your vitamin D at the ideal level, it will affect the omega-6-3 ratio. Absolutely, that's profound. Nobody knew that, but it's related to research that comes out of the UK on dementia and preventing cognitive decline when they tried a decade's worth of research just on B vitamins, and then they added in omega-3, and they go, wow, that was the magic, was the omega-3, which has to do with the ratio. So here's vitamin D compared to omega-3, specifically and only. Same thing, it says, here's the target, right? This is vitamin D down this way, so 70 is right here. It's between 82.5 and so 70, we're going across. And what do we see? As we have this level, this of the data that just these 22 people, this is not etched in stone. When I add my other 60 people in, then that will be even a more refined graph. But this is amazing, this reveals this much. So here's 8, which is the ideal level of omega-3. What does it show us? It basically brings us not exactly to 70, but pretty darn close. So this shows us where the ideal levels are. Let's go on. So homocysteine. So homocysteine correlation from basic lab data we have. I'm going to show you homocysteine, why this is the case, but you look at this. Homocysteine, again, here the ideal is 6 from that lab spreadsheet, right? From that spreadsheet here, we have homocysteine right over here, homocysteine. 11.4 is the conventional 11, the sweet spot in my view and many other views is 6. So we're comparing these two. Okay, so homocysteine, the ideal of 6 level, if you're at that level, homocysteine, your omega-3 levels will be pretty comparable. In other words, they cross. If you were to extend this line down a little bit, it would cross right about here. This is your healthy ideal level, which would be omega-3 of 8 and of 6 of homocysteine. That's profound. That's never been revealed like that before. So here we go. Again, the omega-6-3 ratio, we find that the ideal ratio is pretty much right on the number at the intersection. If you bring this down, right? If you come across and say, okay, at this ratio of omega-6-3 up here, what is my homocysteine level? Right around 6 or 7. So both of these are equally important is the point. Okay, homocysteine, it increases during aging. Here's that 11.4, and it says from studies done in 1999, for the average male in the United States, he crosses that line. In other words, he exceeds, he goes over that line in conventional medicine in terms of homocysteine. For women in the United States, it's over the age of 75 and over. However, if you're looking at the ideal level, way back from 12 to 15, they're already over the ideal level and they're starting to decline and head towards outside of the conventional level. And here's glutathione decreases during aging. We've talked about this before. Here's at birth, you're 100%, and it decreases all the way to age 90. So what are we looking at? It's a very tight correlation. So by age 50, let's say, we're down about 50% at age 30. We are down 100% by age 65, and for women at age 75. Okay, so basically, you need to know homocysteine increases with age, right? Homocysteine here increases with age. Glutathione decreases with age. What can we do about this? Well, one is, as we get older, I just said one increases, the other decreases. You go, well, so it's like a dam. The water's filling up, and it's not getting below. It's choked off. That's one way. So you're looking down this way. But the other is, the reason that homocysteine increases with age is because we are deficient in the cofactors that makes this whole little wheel go around. And let's pretend we're all the same person. No, bio-individuality. We're all one size fits all, which is a kind of moronic way to look at it, but simple for this particular explanation. Well, the 3 big deficiencies are folate, B12, and choline. You're deficient in those, then that keeps homocysteine from recycling to methionine. And it keeps other things from being made. When you keep other things from being made, like SAMe, for instance, and these all beige things, are common mutations that people have. So these people that have these mutations have a higher need of the folate, B12, and choline, depending on their particular mutation. They need more of it to work normally. So as the diet becomes less and less nutrient rich, or becomes more and more nutrient poor, they're going to suffer faster cognitive decline, autoimmune, et cetera, issues. Okay, there you go. So other secondary cofactors are B6, 2, 3, and zinc, of course. But if SAMe can't be made, this enzyme down here can't function. So it all contributes to everything. This is one of the reasons why we have glutathione deficiency. So viewed in a different context, lifestyle, disease, drugs that result in low folate and low B12 will make your homocysteine higher and lower your glutathione and create cognitive impairment, otherwise known as dementia at some particular stage, otherwise known perhaps as even Alzheimer's, but it goes that far. So what I just want to show you is COVID-19, this is now a Swedish group saying COVID-19, I think it's an attack on the methylation system, which is what we've been talking about right here. So they're saying homocysteine increases, glutathione decreases, and we talked about the deficiencies. This whole thing is called methylation and going down to make glutathione transsulfuration. But this is now 2021. These ideas are coming together as like, my gosh, it's vitamin D, it's glutathione, it's methylation. You bet it is. So here's another one, just ending with insulin correlation. We talked about insulin before and glutathione, right? Here we go. Here's the healthy ideal. Insulin. We're going to compare it to insulin and HDL, high density lipoprotein, insulin and triglycerides, insulin and cholesterol. So what do we have? We find, so your ideal level of insulin is 2 to 5, by the way. Ideal level, which is the level I have my clients look at, and we get them down to that. What we find is we can get at that level. See this? I made it a black line to make it more obvious, is that our HDL comes to around 100. So they're saying the ideal level of HDL is around 100, which I believe is true, and many other people do as well. But now it's saying, get insulin correct, your HDL will be higher. So if you're doing something to bring down your HDL, your cholesterol, you're doing something, an unhealthy thing. So here we go, insulin and triglycerides. Insulin, when you get your insulin down, you're going to find that your triglycerides, let's read this. Here's your insulin right here. When your insulin level is to the 2 to 5 range, you're going to find your triglycerides are really going to be around 75. As your insulin rises, and we see, as your insulin rises this way, up to 30, 45, 60, as your insulin rises, your triglyceride becomes absurd. And we see this. This is what's called diabetes. Diabetes is out here. This is very healthy down here. Okay, again, insulin. Keep insulin or get insulin into the ideal 2 to 5 range. What do you see? So here we go. Insulin is right here, going across this way. And it shows that cholesterol will actually increase to 300 to 400 range as your insulin comes down. You go, wait a minute, I've been hearing cholesterol is bad. It's real bad. We shouldn't be having anything over 200 because that's the conventional range. Well, that's garbage. That's absolutely garbage. There's studies have been coming out for the last 3 decades in Scandinavia and now throughout the West. And we've talked about cholesterol, that it's been totally bogus. And I want to go one further. Now I'm going to look at cholesterol. Insulin now we're looking at insulin again, right? There's the range, there's the ideal range, 2 to 5. What we find, and I'm repeating this, is that your ideal cholesterol is between 350 and 400. And what they showed in a number of other studies in Scandinavia, just being off to the side here, is that they found that your LDL and total cholesterol needed to rise as you got older, and that was associated with lower all-cause mortality. Higher LDL and total cholesterol was associated with lower all-cause mortality. Not in the United States. Not in the United States. They don't look at it that way. So the healthy ideal here is now omega-3. We're comparing omega-3 to cholesterol levels. We find, here's our omega-3, right? There's the 8. Omega-3 ratio is not the ratio. Omega-3 is 8 is what you want. And it also shows that as you get your omega-3 in the ideal range, 8, which very few people do, your ideal cholesterol will actually be between 300 and 400. Makes perfect sense because your cholesterol is your precursor for your sex hormone, your estrogen, your testosterone, DHEA. If you cut back on producing cholesterol or block it from some medication, you're going to suffer severe consequences. So the third thing we learned from COVID that will change how you protect yourself from the next flu season is the risk of severe COVID-19 will be stratified by omega-3 index quartile. Omega-3, we've just been looking at that, meaning the lowest level of omega-3 have the worst outcomes. And here's 2 studies from 2021, 2022, Chile and Iran. Omega-3 index clinical outcomes of severe COVID-19 preliminary results, amazing. In 2022, So these are very recent, saying omega-3 by itself, that we just showed you in the scatter plots, how important that was. That's why every doctor should keep their ratio, and they can see the answers are obvious. It's not that difficult to see. This is the importance of omega-3. It does all these things. Immune moderation. We're not going to go into all this, but say immune support, inflammation resolution, decrease, antiviral, psychosocial. Absolutely. It's about depression too. And this is the big ideal. This is the omega-3 polyunsaturated fatty acids. Kind of what I showed you on vitamin D, that when you have adequate number of omega-3s, you have a balance between ACE2 and ACE1, and that's a big deal. Okay, you have anti-inflammatory, it reduces coagulation. That's a big deal. You hear a lot of people who eventually die when they are in the hospital on ECMO and ventilations. The part that eventually is the stroke of death is a clot. So they either get a heart attack or they get a stroke, and that's what sets them off. So this all is from long COVID and long chain fatty acids. Psychoneuroimmunology, implications of omega-3 long chain fatty acids in delayed consequences of COVID-19. 2022 Taiwanese study. Amazing, completely amazing. Brain behavior and immunity. This is recent stuff and saying it's a big deal. Pretty much closing it down. Omega-3 fatty acid acting on different elements of the immune system. Not going to go into all this, but I'm saying it is real. It's a big deal. It's very well researched, and you need to know it and you need to have it, but know there's relationships. Don't go, I'm deficient, I'll have that. I think you need a collective understanding, and that most doctors, I'm doing what most doctors did in the 60s. You kept all your data and you saw your patient population, your client population, and the data itself shows you where the answers are, shows you where the ideal locations are. It's amazing. So basically, omega-3 fatty acids, through their anti-inflammatory mechanisms, inhibit the production of pro-inflammatory mediators like IL-6, which is, you get that measured through CRP. So for instance, CRP is right here. That's really what we're measuring. Tumor necrosis factor, et cetera, et cetera. It is a big deal. Okay, so omega-3 from those labs, omega-3 compared to homocysteine, omega-3 compared to cholesterol. What do we see? So let's go, here's omega-3 on the vertical. So 8 is ideal. You know that, 8 is ideal. Over here, 8 is ideal. So we're now looking at, that's our ideal. If we get to our ideal, right here, so we have to be on this side of the graph, so to say. It shows that homocysteine will decrease. So we showed you the flip of that graph last time we were talking about homocysteine. You get your omega-3 as close as you can to 8, your homocysteine will decrease. You need to know that, and you need to do that. So omega-3 relative to cholesterol. This is so mind-blowing. As you get your omega-3 to 8, the ideal level, you're going to find your cholesterol will increase to the ideal range between 300 and 400. That might be a shock to you, but it's not a shock for the rest of the world. Okay, so coming up next is the 3 most important things you can do to protect yourself this flu season or next flu season or the next pandemic, and what to do with this information. Till then. So if this is something that you're interested in, that is a topic that I obviously go deeper in terms of labs, in terms of how to do it, in terms of why you would want to do it, various topics, as you've seen that I've done in the past, then please let me know below in a comment. Till then.